how do we maintain quality data? This is the only dream which remains unfulfilled for me at the fag end of the career. Right from beginning, we worked in one of the best institutions, but I am looking for, Mihir, would you please join me? I am taking this opportunity because Inder and Mihir have been really prolific writers and voracious readers. So what we need is, I'll briefly tell what Vattikuti Foundation would do and what you should do, and then we'll work out the logistics. Our principle is democratically, we don't want to segregate the institutions from academic and private and individual. I don't care. Only thing is, it cannot be everybody doing one case in a day or something. It cannot be a part of the whole thing. So foundation has already decided, where we have requested at ALS Belgium, our Vattikuti, OLB Vattikuti Institute of Robotic Surgery, we have started the database activity. What foundation would do is, fortunately, sister companies are what you call the IT-based companies. We are already way ahead in getting the database done on Salesforce, and it would be HIPAA protected, and it would be totally online, giving access to the centers, and totally paperless. It would have, like partial nephrectomy, we've decided on minimum fields, but if you would like to expand and store more fields, you would be able to do. It would be totally non-partisan. You can trust us, because we are going to code the surgeons as well as the centers, and nobody would know where the data has come from. So your data would only be given to you or your collaborating group if you do, total sterile data, and collective data would be reported to everyone. For you to see that he has done, like you see, so many, 4 people are interested in the software, because there would be close to 100 software. It's for you. ROOMA was telling about incidents that she presented a poster, and she learned that another Apollo hospital group has another 9 cases of myomectomy. But this is a platform when you can identify interest, collect your data. So we will give you the statistical support, which is available. We'll provide you with the software. We will even provide you with the data feeding support. And that's where I need input. Centers beyond 300 cases, I've already offered them individually. I'll give them a fellow. The fellow would be trained. At the same time, he will, because let me tell you, my experience of data feeding clerks in India is not very good. It has to be somebody who knows the domain knowledge. And when we are talking of recording the videos and everything, we need a fellow. And we'll train the fellow for video editing and things, and whatever needed we'll give. Now, my issue is, how do I collect the data from the people who do not have 150 or 200 cases? Some suggestions had come that I can give fellow between 2 or 3 institutions, as I mentioned. But the third thing is that, like retail business, you give me a completed record of a quality data, and then I'll reimburse you per case, whatever sum we decide. So the whole idea is, none of your data should be, this is the first stage, that let us get into the logistics of collecting data. And we are already planning a prospective study, partial nephrectomy. Because the whole idea is, until you have high quality, uniformly maintained, say the externally validated data, which is very tall order and will spend huge money, people would not respect single center studies. Why this robotic consortium in bladder cancer has changed the whole outlook? I'm sure you were there when it was first presented, and the comment was that this is the last nail in the history of open cystectomy, and that is true. So I think, in brief, foundation would do everything, but foundation cannot do is maintaining the data in uniform standards and collecting it, not sitting when you are preparing a paper and putting out the records and all. So Mihir, would you give your thought, because you have the best of both. You have seen Indian problem, you know about US, how we should go logistically. Foundation is open, but myself and Raj 100% agree, that if we have money and if we have to put every money we'll put in posterity of having high level of evidence published by the Indian origin surgeons in the best of the journals.
So thank you, Professor Bhandari, for this. So I have, even within the US, I have had the opportunity of looking at various institutions and the diligence in which data was being collected. So I'm going to give you two examples. So in my former life, I was at Cleveland Clinic, and despite all the reputation or despite all the institutional name, for example, even for its most known operation, partial nephrectomy, there was no actual formal database. It is amazing. It was basically, if I was the resident or fellow interested in looking at one thing, I would go through the charts, I would make my Excel file, I would publish the study, and that thing would then get lost in translation. On the other hand, at USC, Don Skinner, from the last 20 years, all the research funds that he generated were all put into dedicated databases. So for every cancer, there was a designated data manager, and there was a principal investigator physician who was in charge of the data. Nobody could publish anything from outside the database. So if I looked at 5 charts in the files and made a little poster, it could not be submitted unless the data manager actually approved of the data. So nobody could look at data, nobody could do statistical analysis. So the in-house statistician would only do an analysis if he got that data from the database manager. Now this ensures that everything is done uniformly. Now I understand the problem that non-medical clerical folks may not be up to speed. The problem with having fellows and residents do it is it's going to change every year. What one person did one year, then somebody else comes in. There is no continuity, and you do need continuity for somebody looking at the data. What you could do is have the fellow validate the medical portions, but what is being entered and the way it is being entered and how it is being entered has to be by one person, and maybe that can be standardized, and there will be a level of training that is involved. From a practical standpoint, the one thing we did at USC is we looked at the database and we actually saw how many fields we were entering. So for bladder cancer, I forget, there were about 895 fields. And then we looked at our papers and said, it looks very impressive that you're collecting such detailed data. We looked at all the studies that were done and found that about 500 of those fields were redundant. They were never used even once in any analysis whatsoever. Now there is a lot of time taken in collecting, entering all these fields. So you have to evaluate your database not just for inadequacies, to add things that are important, but to remove things that are redundant. Because every field you add adds time, and it adds expense, and it decreases the chance that your database will actually be maintained as you should. So it should be one person channeled. I think that is very important, so that quality can be controlled, not multiple people entering in. Only one person should have, whoever is a designee, should have the ability to change data. And anybody wanted to looking at it gives a request, this is my study, these are the fields I want to look at, and they can then process that. And that should be the way. Otherwise, if there are multiple sources, it becomes invalid. The most important, I think the most impressive and efficient database that I have seen is what is done at Sloan Kettering. What they do is the data is automatically extracted from the medical record. So for example, if I see a patient in follow-up, or biopsy data or CT findings are done in a way, their system is called CASES, C-A-I-S-E-S. It's a free thing. It's a very difficult software to use, so you need to be trained in that, but it's actually a freely downloadable thing, so that they say that 78% of their data fields are actually auto-populated through lab reports. Nobody has to physically type in a creatinine value. It should come in from when the patient goes in there. So their operative notes have to be dictated in a certain format. CT scan findings have to be reported in a certain format. Biopsy reports have to be given in a certain format, so that you can self-populate the database from it. I think since most people are going with electronic medical records here, it is an important thing to keep in mind that you should design that medical record so that you can also use it for research purposes. There is no point in somebody doing all the dictations and then somebody having to physically take the data from there and then manually enter it into the research database. So that could be the ultimate role. So whoever is the IT person should be given which are the data that will be populated, so that you have to report them in a certain manner. But I think with these in mind, this is becoming very important. In the US, for example, with the new healthcare reform, quality of outcomes reporting is going to be very important in getting paid. And so if you don't maintain that, and people who have a lead in maintaining outcomes will actually have a significant advantage. And it's not going to happen overnight. Obviously, this is a learning phase, and you'll have the first generation of system will have a lot of problems, and then as time goes on, it will become better. But if it is uniform within this group, at least there is a lot of opportunities of doing collaborative studies. So since most people are in the process of creating their database, if there is a common foundation based on which everybody agrees to collect data, I think again the opportunities will be huge.
I'll come to the discussion. I would answer the question here. The model is that all we need the fellows is to feed the data online and complete the data concurrently. Rest of the functions will take on cloud servers, and we will manage it. We will give the reporting. We will do the whole thing centrally. And foundation is one which is not an institute. We'll definitely have these institutes as PIs, that we are doing partial nephrectomy with, because having a data would not get you the papers. We need somebody who will energize those papers, follow the standard editorial guidelines. Whoever has largest number of cases gets the order, but there would be somebody like Alex Motry is taken, but all the data may not be with Alex Motry. Radical prostatectomy we do with Moneyman and with our RoboSurge or somebody. We may ask Procard to do bladder cystectomy. We may come to you for something. Because see, our network is pretty huge, and we would be very happy to do it. Everybody has contributed, and we wrote to about 35 people, and we got all the consents, including Jim Portal and the Payne Party and everybody. So what I am trying to say, this is a great opportunity for Indian folks to get linked with already stalwarts, those who produce quality data, and quality will go up. And we are setting up uniform standards. It would be open. There would be hundreds of debates on what data fields. But what we are looking at, the minimum necessary data fields. And more than that, whatever you want, we'll preserve it for you. It will be reported to you. And this is what we are planning. Still, I would request that in your institution, please think and talk amongst disciplines and come out with a plan. How could we support you? Foundation honestly wants to do it. How should we do it so we can make it to happen? I still don't want, if you leave it, there is a lot of excitement. We have discussed, Dr. Gupta, Mahesh would have seen in Transplant Society, we have had such things, but finally, maybe one or two would do the database. All I'm looking for, how do I mop up everything of quality, irrespective of the specialty institution? So I think we have left the thoughts. We will correspond to email, because now we have all your email contacts, and I think none of you would have objection if we send these email contacts to the entire group, because you make new friends, and we would like to create an interactive forum when you are interacting more, rather than all of us interacting with me and that. So now we can have brief comments. Yes, Dr. Gupta.
The idea is very good, and this is what we are striving for many years, which we have been lacking in our whole career. Now, I have to only make 2 points about this database. Number one, what kind of quality of the data we are entering in this database? How you have generated this data. So this is equally important. For example, operating time or blood loss in the theater. If somebody has just bogey, put any 10 ml, 5 ml has got no meaning. Second thing is how your pathological, for example, I'm talking of CA prostate because that is my area at the moment. Histopathology. Who has reported, how it has been reported, whether it has been validated by others or not. Or radiological finding, MRI findings or something like that. But there may be different radiologists, there are different machines, there are different type of reporting has been done. And if we depend on that, then everything go wrong. Second, the most important concern is the follow-up of your patient. You might have done 100 radical prostatectomies, but if your outcome is not good, long-term, I am talking functional, oncological and all that, then what is the meaning of that? Who is going to do the follow-up of these cases for next 5 or 10 years? That is equally important. If you don't have a 5 or 10-year follow for your radical prostatectomy, the data is useless.
See, I'll just give a brief comment that you made very valid. I have the mic. You have very valid comments made, and about the electronic following, we will provide you the technology to do that. But there is no way anybody else can follow your patients. You will have to do it, but we will provide. We are in the next stage. We have a company in San Francisco of our own group, which is expert in handheld applications and iPad applications. In order to facilitate real-time quality data, I would not mind bringing the iPad application given to the patient that he has a pain, he clicks it there, it would land on your computer. We'll do everything possible, but there is a role which I frankly and again tell, which you as a clinician will have to realize the data. Answer Dr. Gupta's another question is that we are standardizing, but I know that it would not be in one day, like standardizing histopathology or reference pathology will take its own time, but we are at it. That's why we say at least let us get into logistics of good or bad quality and then gradually go into prospective validated therapies.
So one question is that, so if you look at multi-center databases, like what is being proposed, that is always going to be an inherent limitation, that you cannot compare the skill level of a pathologist of institution A to B to C to D. So that is why if you have a specific project, you can have a third party review of all the data so it is uniform, but that is impossible to do in this kind of a setting. So as long as the minimum parameters are set, and maybe just to standardize quality, I mean this is a tall order, you could have every year an audit done of say 5 cases that is being validated externally, just to see if there is any deviation or there are some data that need to be looked at in more detail. So that can be done, but that is always going to be a limitation of a ongoing database. It can be rectified by quality control to a certain degree, or if there is a specific study, like you're saying, locally advanced prostate cancer outcomes, and it's a prospective study of a finite number of cases, the 300 cases to be accrued, then for those 300, you can say, okay, their pathology has to be reviewed externally by a single center, so there is no multi-institutional bias in reporting of Gleason score, grade, margins, etc. But you can't do it for a actual full database.
We will have brief comment from PARVEEN and then Zamir and then Arun. Arun was the only one who wrote to me about that he would like to talk about database.
Thank you very much. Sir, at the outset, I must request you that when we are making this foundation, Robotic Foundation of India, why not give the recording system along with the robot wherever it is being installed, in the sense that we find a lot of difficulties in getting the 3D recording of, so we should zero down to the system, video recording system, that this is the best video recording system which can be used for recording all the cases, and then they can be put on the Dropbox, and then you are able to access those videos. One. Second point is about the Michigan Bariatric Registry. They have done an excellent job, and I would definitely request all of you to put that effort.
Berkmeyer.
And then ultimately gain knowledge from those people, and then we
are already in contact.
Right.
Bringing out 1% down in mortality.
Exactly.
It's huge from the accredited centers, not the general centers.
Exactly.
So I think it's a wonderful work in JAMA which was.
Exactly. Thank you.
I think Zamir and then Arun.
So, as a specialty cardiothoracics, we've always been heavily scrutinized by the media and by the regulating authorities in UK and US. So we are by law required to submit data to our respective societies. For my GMC revalidation process, I am required to submit data to the European Society, and so a lot of my data is already going to the ESTS, also for accreditation of my thoracic surgery program by the European boards. The question is, if you are going to set up a new database, will that mean duplication? Will that mean because your database is going to be developed by somebody else. We've already got a developed database to which we are actively contributing data. So, is there some way where we can
I'll
drag the
respond
two?
to you. I'll respond to you. If you have any other question, I'll respond.
No,
to you.
that's the
No, number one question is, you are not forbidden to use the same data anywhere you like, isn't it? Or is it copyright of the GMC?
No, you're not forbidden. It's my data.
Second thing is, we are beginning with one database, that's prostate and partial nephrectomy. The specialties, thoracic is the next I can see in my vision, and then gynecology is building up. And we are not deciding the fields. What we do is, like prostate, I collected 10 places, like Yash Tiwari or our database and from Procard. And then we said that let's sit and do the database. Similarly, for thoracic, we will begin with you and we will use the same data points because they won't be different.
Okay.
As regards to the feeding, we failed in Medanta. First, what you said, we wanted to link up with HIS and do the same thing, and it never worked. It never worked. 3 times our engineers came here to get an access. It never worked. So that's why we decided it would be standalone database. You can use your laptop, have access, and you feed your data, and it will come to us. So that problem I can't solve, because that even in Henry Ford we are not able to solve, because they are totally rigid walled thing. They don't let you do anything with the hospital information system, and that's why our residents have to feed data again for the route.
No, we're not talking about HIS. HIS is a Medanta database.
No, whatever it
I am
is.
talking about a database which is an international database for cardiothoracic
So
surgeons.
you give the fields, and but what I say that will work out interface. How can you minimize? Point is well taken that we have to minimize the number of the same data is fed, but then we'll have to sit. What can we do? Because we can build in a kind of a connection between your data points and our database, which technically we'll have to look at.
So, just like Dr. Bhatia mentioned, the recorder being part and parcel of the robot. Similarly, the database, the software, and the computer system should also become part of the robotic system. Right now, we are in the early stages. Like many of my friends here have done many surgeries. I've only done 55. So, if in our early phases where we are, taking off programs, if we incorporate it, make it, a habit, a part of a checklist sort of a thing, where the data has to be entered, it will automatically catch on. I wanted to mention the Michigan example, which PARVEEN has already mentioned. Now, I would like to talk about the bariatric surgery, because robotic bariatric surgery is expanding in US. It's going to expand here as well. There are a few of us who are doing bariatric surgery here. We are quite happy to, pool in our resources,
Exactly, that's
make
what I'm
the
going.
database, and at the same time, unlike say radical prostatectomy or nephrectomy, where you are talking about robotic surgery replacing laparoscopy, here it's not replacing. So in addition to robotic bariatric, we will also be able to generate data and studies comparing robotic bariatric with laparoscopic bariatric,
So I
which
think-
would make
yeah,
a series right from the beginning. So that was point one. And second point is that as we've got associations in the past of surgeons in India. I have been vice president of 2 of the organization. One is IAGS, which is the laparoscopic surgery organization, and other is the obesity surgery, members of which Dr. Narwadia was here, Dr. Praveen Bhatia is here. And what we have made is a Yahoo or a Google group, where all the members have been included in the group. We can share mails. You just have to click, you send the mail, the entire group reaches, and it acts as a big support group. You talk about support group for patients. Here we are talking about support group for surgeons. Recently, some incident has happened, and our obesity surgery society has been able to, just that email from this group has been able to help us a lot. If we have a group, I am interested in esophagus, I have just got to see some people. I get to know who would be doing what kind of surgery. You post a problem, you post a complication, and immediately advice comes. This has worked wonders in our obesity surgery group, and I'm sure it will do the same in the robotic surgery group, that I am having problem with port placement. 5 suggestions will come immediately.
So I think that those points are very well taken. Before I give to ROOPINA, all I would like to say, this is already advantages are being accrued of putting you as a group. work out your focus groups and start initiative and tell me what kind of support you need from foundation. You identified rightly the bariatric group, or for that matter esophagus or thymus. You work out, that is the objective. Because see, otherwise you would have not known till it either would have come as a publication or it would have been presented in the society.
So I would request you that if you can make Arun Prasad as the administrator of the robotic Google group.
No, we will definitely use all the skills, and please write to me,
I'll write
because
you.
I have a bad habit of not taking instantaneous decisions,
So all I
which
need-
I have to retract
all-
later on. We have done in societies, so I will absorb everything, but everything is acceptable.
So all I need is the email IDs of all the robotic
Right,
surgeons of
we
India,
have
and we make a group.
anybody who has a reservation in giving the emails, I'll withhold.
Definitely.
Otherwise, I think it would be very good. I'll circulate the whole list of the robotic surgeons, and we'll keep updating it for you as and when.
So the group goes as an invite. So somebody who doesn't want to join
Right.
can always.
Thank you very
reject.
much. Thank you so
sir.
much. Now, Arvind, I'll take Rupina.
Just a quick thing,
Yeah, you were-
reiterating what the doctor said here. We have an AAGL society in the US which is called American Association of Gynecological Laparoscopists. We have a listserv of all the people there. So every midnight at 12, if you want to wake up and see, there's a listserv that goes out to the entire group every day with questions that people have asked, and people all over the world, including India, will respond to the listserv and the questions. So that is a very useful tool. I think that would be really
We will-
important
we'll
in
build
helping
on this.
people. So you
Wonderful.
can build a listserv of the robotic surgeons in India based on specialties or whatever to help them with that.
A brief comment from Bindal, and then Soma.
So this is the question to Dr. Mihir. He mentioned about planning a randomized control trial between open and robotic cystectomies. So how do you plan a randomized control trials taking into issues the patient preferences and the surgical outcomes when you are convinced that robotic is a better option than conventional thing?
No, I mean, my being convinced, answer the second point question, my being convinced and the data being out there to prove it would be two different things. So clearly, we don't have data long-term oncologically that says we feel based on all the surrogate evidence that it is likely to be comparable, but we don't have the data. Secondly, we don't even have data to show whether or not by doing the surgery through a minimally invasive approach, we are actually reducing morbidity for bladder cancer cases. So in that scenario, I think right now is the only time it is possible, because it is still unclear that one is definitely better. If you were to try to do a similar study today for robotic prostatectomy, it would be a non-starter because nobody would agree for an open conversion. Currently, for bladder cancer, there are still more open cystectomies being done than robotic. So more patients are getting that. Patients are still interested in robotics. So I think there is a finite time period where you could do a prospective study. Once that passes, your chance of doing a prospective study are gone. There are currently 3 prospective randomized studies ongoing comparing radical cystectomy to open cystectomy. The only issue therein is that all these 3 are doing their diversions extracorporeally. So then you would have to either do a study comparing intracorporeal diversion versus extracorporeal. But we thought the best thing is to do a fully open operation as is done and practiced over 3,000 cases at USC using a particular technique, and to do a completely intracorporeal operation robotically and then see if there is any true difference. So right now the reason why we are pushing for it is because we feel that there is an opportunity and patients will agree. But as you're right, I mean many studies
I
will
think
close down.
this question doing the
How many percent are done open in USC, open versus robotic in USC study?
So just to answer that question, when we joined in 2009, they were doing about 175 to 200 open cystectomies a year, and obviously no robotic cystectomies. This year, they will be doing 170 open cystectomies, and we'll be doing about 110 robotic cystectomies.
So, Vivek, this question on RCT and surgical is a very huge question. We can talk for 2 days. So please talk, because there are lots of issues about RCTs, and when do you, many studies when you have a 30% effect size, ethically you have to close and put the Pocox thing. There are so many things, I think. Now I have Soma and then Mahesh will talk.
no, about the data management, what I mean to say is that there is already established data management like colorectal, liver met survey and Asian cancer registry. How it has worked is there is one person who is coordinating, like in this case you say foundation, you set up a modules online, for example Euro, GI, this one, user ID password is given. We are a part of in Manipal since last 7 years, along with 18 countries and 130 institutions. Every week Sunday you said, see, robotic is not a huge number, any institution have 5 volume per week. So there is already a setup online, user ID password is given to department to the institution. Every Sunday they sit and just upload prospectively. And that software has a built-in, statistics which you can take up. So I would say that you set up a module, just give user ID and password and send a mail.
That's what exactly.
Sunday you just do it, and every Sunday everybody uploads it, and it's very easy to do. It has been happening for last 7 years. That is the best way to start, rather than everybody taking back, re-entering it double time.
No, thank you.
We have a cruise group in Urology Society. Exactly same idea. He collects the whole global data. Now he is like say stones, Stegon calculus. So what he has a format in how the case should be entered. So moment you finish the case, you open your site. You are already enrolled into that study, and you open this. You are there. And you open the site, and then according to that format you go on feeding the thing. So what happens that my data, his data, or there are about 10 groups from India who is feeding the data, they are same. And now they have published 10-12 paper on stones, and then they are now doing the randomized studies and between the narrowband imaging and not doing narrowband imaging, and they randomize. They finish. Of course, then they also give a support for having certain equipment and thing. So best thing is now that you have the IT people and you have the people, you first collect the what format you need.
No, I think
and then what we have to do, moment the case is finished, we enter the data. Then when case is discharged, we enter the data. Now after 1 or 2 months, I get an email from the secretary. You have this case number, you have not filled the data. There's no follow-up. So go and do that. So,
yeah, I think we are on the same. Arvind, and then just hold on, please. Arvind.
Sir, I will once again echo the suggestion which Praveen gave about this robot now coming with an inbuilt 3D HD recording system. There's a recording system which was supplied recently. Sir, I want to listen. There's a system which was given recently. It came to our hospital. We tried it. In fact, it was a very precious case where we did not use our system. We just put it to the system, and at the end we realized that it was blank. Although on the screen it was showing recording, but it never recorded. So if you can get hold, and there are now companies which are giving 3D HD compatible beautiful recording systems. So somehow if those could be made a part of the package, that when you are ordering such an expensive machine, 7-8 crores, maybe this equipment
I think
comes as part. I mean, price included or whatever. But
there are
it should
lots
be a
of
part
things because unfortunately most of the negotiations, yes, will bear me out, are done by CFOs. And they have no idea. They are looking at the lowest price.
What I'm saying is, what I'm saying is that even the cost could be included in the thing. But
yeah,
like you are saying that okay,
point.
robotic card, this, these are essential components. So similarly, because what happened when we, at least let me share the SDRS experience. When we bought the robot, 8 crores was sanctioned. Few months later, when we went to ask for a recording device worth few lakhs rupees, it was not done.
Right, I understand that point. Very well taken point.
One comment on that. There was a mention about this cruise database, and one point to take from that is that it doesn't have to be an open-ended database. In other words, you don't need to be entering data for perpetuity. So what they did was, for say Stagon stones, they stopped after 1,000 patients were in the database. You continue follow up on those 1,000 patients, and you will always have a data set of 1,000 stone patients that you can then, that are continued followed up, that you can use that data to answer new questions. There is no advantage in keeping that database open and making that 1,000 into 5,000 and 10,000 and 15, because at some point the validity goes away. So for each cancer, depending on what the outcomes are, you could say at 500 or 600
Sample size.
The sample size. And even for databases, it doesn't have to be ongoing for everything.
Yeah, I think you have some comment to make.
I'm Dr. GOVIL from Apollo Hospital, Delhi.
Right.
I just wanted to add on to what Dr. Arun and Praveen have said. I would say that since it's a small group, we should further group them into specialities. Like, I would not be much interested in prostatectomy robotic. So, robotic colorectal group or a bariatric
That is
group.
coming in the next discussion. That is a full agenda. How do we run this? This we have run to bring you guys together, good or bad program, to put everybody to know what is happening. Ultimately, it is going to be specialty specific, but that would come in the discussion.
The biggest hurdle to the success of these programs is a conflict between individual benefit and a group benefit. Invariably, when you have groups contributing between 200 to 300 cases each, at the end of the day, one guy writes the paper, and the other guy becomes the chief PI, and the other guy writes a paper, and you get an invariable name somewhere in the middle of the database. And for individuals who have contributed 250 out, and the other guy has contributed 280, the guy with 250 loses out, which always invariably makes you believe, why should I be contributing my data to this database? And when you look at these manuscripts as an editor, when you say, I've already got 1,000 case series, why should I be looking at this individual guy's 20 case series? And when we are beginning in a smaller country where data is still building up, I get manuscripts which say my first 50 cases, and I'm happy to even publish them. Even though I've got 3 other people sending me papers saying my first 50 cases, my first 50 cases, and it's because I know nobody has more than 50 in this country. I'm happy to publish those 3 manuscripts which have 50 each. Once I put in my data to this database, my 200 cases are gone, because honestly I cannot rewrite that paper on the same date from the same database.
No, I don't agree. I'll respond to this.
So unless I put those 200 cases with a totally different take, which is not what the primary take is. So we need to answer this.
Yeah, I'll answer this question. It's very, very easy, and this is not theoretical. Once you have a database, 3 things are possible. You can write on your own material if it's enough. The whole group is there, and whole group, nobody is going to write. If somebody doesn't take a lead, we will create a PI. He will write for the entire group, and that it goes by pro rata your contribution of the number of cases. Third thing is, you can create closed user groups from that, and you can tell the Vattikuti Foundation, if we want 3 of us want to write on bariatric surgery, we'll give 3 merged data to you to do that. So I think it is possible, but logistically I understand your point that it has to happen, which hasn't happened till date despite several efforts. Hoping that we will be able to move ahead. I think I would, ROOMA, last comment, because you were the last speaker and I am compensating you for that.
I actually agree to Dr. Somshekhar that in the beginning we should start that with a module online, and surgeons can themselves field where the centers are not, and you can't provide a fellow. The second, one small inquiry regarding this, when we put the database and you said we could extract our own data and produce our
No,
paper.
you won't be able to extract.
Well, take the information and publish separate papers as well. Will we get the statistical help from the Vattikuti Foundation?
Vattikuti Foundation will be looking for it. It's a very rare commodity.
Yes.
And
because that's a difficult
if I
part.
get a big statistician, he will eat away most of our income, but he may not be good enough for you.
Okay.
In our experience, we have created our fellows as wonderful statisticians. They run all things on Stata and all, and that's what we'll try to create. But we will really help you.
Help that.
Yeah, we'll help you.
Thank you.